happy that Maddie Sterling is here to talk to us about home care workers' contributions to patient care and heart failure. And Maddie is visiting us from Weill Cornell, has done work in this and other areas, and is meeting people throughout the day, considering a position here. We'll see if we can maybe make that work, but without further ado, Maddie, delighted. And I should say, Lee, I saw you were on the call. Apologies for sort of usurping geriatrics grand rounds, but so thanks for Lee for helping us engineer this. But without further ado, Maddie, take it away.
Thanks, Dr. Linder. Hi, everyone. Okay, so I don't have any disclosures. Today we'll be going through I'm first going to characterize home care workers as a workforce. I'll then go through an emerging body of evidence from my lab looking at home care workers' contribution to patient care and heart failure specifically. What I hope I can show you is that this applies to a number of diseases. And finally, we'll wrap up with some other areas of my research program in home health and then get into some clinical and policy implications you can take home with you or to clinic. So in typical grand rounds fashion, let's start with the patient case. Just move this. Let's see. So this is Mrs. Jones. She's an 80-year-old woman with HFrEF, hypertension, and osteoarthritis, and she came to our hospital with shortness of breath and light swelling. Our team in the hospital found her to be having a heart failure exacerbation. It was actually the last one she had, and second to last 3 months, which is pretty common. Turns out when we did some digging, she's a recent widow and without any help at home, and she wasn't taking any of her medications. She also, in New York City, lived on the third floor walk-up and her worsening arthritis, and so really could not get out to the pharmacy to get them. Our hospital team diuresed her. We restarted her on meds, and her symptoms luckily improved. And then, she was evaluated by social work and PT, and they felt that she needed home care. So we sent her home with some instructions that I'm sure you're all very familiar with, and she was told to follow up with her primary care doctor, which was me. So I'll just keep flipping down. Okay, let's hope for the best. So what are home care services? I think this is a really common thing that you'll probably come across if you take care of patients or you have your own family members. Really, there's a variety of services, and they're designed to support people in the home, either during that post-transition period, that post-acute period after a hospitalization, or sometimes in the long term, and just someone needing a help with daily living and function. And they can really involve nurses, physical therapists, social work, and home care workers, which includes home health aides, attendants, and personal care aides. And sorry, this keeps.
It's very temporary.
Okay, I'm not going to touch it, but so patients receive care at home along a continuum. This is one of my favorite figures to demonstrate this, just to orient you. All the way on the left are sort of the most informal family caregivers, not much medical involvement. All the way on the right is probably the most high acuity, the hospital to home movement. And where I study is that sweet spot in the middle, which are formal personal care services. So these are home attendants or personal care aides, usually funded through Medicaid. So these state-based programs. In this is also sometimes family caregivers who are paid to be home care workers, which I know is here in Illinois as well. And then also Medicare skilled home health. And this is services provided through Medicare under the care of a doc when someone needs skilled care. These are usually in 60-day episodes. And within this bundle of services, you might get a home health aide. And so today's talk is titled Home Care Workers because I wanted to encompass sort of all these different types of home care workers that patients could have. So Mrs. Jones came to see me. This was the discharge summary. I'm sure this, now it's obviously this is a computer printout, but we went through it and, this was her reaction. I think it's overwhelming, right? There was a lot of confusion. The instructions were hard to read, small to read. And I guess I wanted to put this slide in, not directly related to the body of home care workers, but also just to let you know my early research. Okay, I'm having trouble with it.
Maybe trying to, is there arrows?
Yeah, okay. So I would say my early research actually focused on this sort of confusion around going home from the hospital and what do we do with all these instructions? How do we manage heart failure in the home? And so I should note I have a background in epidemiology and statistics. And I was really fascinated in, the contribution or role for health literacy and numeracy. I know we have Mike here at the table and Rachel and others interested in these topics, sensory and functional impairments, social determinants of health. And so a lot of my early work actually really did look at using observational cohorts, how do these factors relate to patients' self-care and heart failure? And just to shout out to the number of folks here doing similar work and sort of data that could still be used to kind of take a look at these questions. But I would say that actually a lot of that work left me a little bit still unclear as to what was happening at home. And I decided to do a qualitative study pretty early on, where I actually just started asking patients, how are you managing? And I'm going to leave you with these quotes for a minute and then call on you about them. So make sure you read. Themes, thoughts, ideas. What stands out?
Just deferring decision-making and information to other people. Like I'm not worrying about it.
Yeah, I think what really struck me was this reliance on others, whether that be the family caregiver or a formal home health care worker. And in all of my training and being a primary care doc, I actually had not known much about home care, and this really stood out and really launched my trajectory of research. So who are home care workers? This was the front cover of the New York Times back in 2017. They're actually one of the fastest growing sectors of the healthcare economy in the US and healthcare industry. There's 2.6 million. There's going to be another million by 2030. And actually we need a whole lot more. We're in the midst of actually a workforce shortage crisis, made worse by COVID. But I think the things to take away are their types of care differ. So there's different names, as you've seen. Their scope of care and training differ, but really all of them provide hands-on care in the home, whether that's personal care, medical care, and are actually often known as eyes and ears for patients. And when you Google home health aid, this is what comes up. And it really frustrates me, actually. This is a side tangent, which I'm going to get to in a minute. I think the more I've done work with this population, and we're going to touch on this at the end of the talk, it's a really hard job. It's demographically mostly women, middle-aged women, mostly racial and ethnic minorities of color, a lot of immigrants. This is often a first job in the healthcare scene. So someone who wants to get in, often there's this sort of ladder to a CNA or a nursing school. The working conditions are really hard. This is low wage work, despite really being integral to patient care. There's manual care. There's some really interesting, challenging tensions with families and patients. And actually, one thing that I'm really working towards is there's a lack of integration into the healthcare team and the medical team, and this perception of really providing unskilled work. And so I hate this image on Google, and actually this I think is more appropriate. I would call it a vulnerable workforce that faces a lot of professional challenges. And one big goal of mine is to raise awareness and try and get at this overlooked and undervalued component of the work. To get at that, our team actually, we surveyed and we did a national survey. So Illinois was in this, and we actually did household calls to about 1,000 households across the US. This was right before COVID. And we asked people, if you had a home care worker, about a third of respondents said they have had one in the past. What did they do? And I think this helps get at that, just providing, assistance around the house. You could see the majority were providing not just help with assistant activities of daily living, but also medical help too. So, I think another part of my portfolio is really trying to get at that piece of the medical aspects of care. Which leads me into sort of, what is the role of home care workers in heart failure, and how did I get started in that particular disease? This is Mrs. Jones. You saw that she, was readmitted a couple of times before that hospitalization where I cared for her. This is data from JAMA Cardiology 2021, basically just showing that heart failure is a pretty awful disease. It's prevalent, its outcomes are pretty bad, and hospitalizations and readmissions are rising despite sort of all the interventions that we've tried. You can see the numbers are going up. And I think what's hard is that patients come in after having the worst, one of the worst experiences, and they come back pretty frequently. And along that trend, so those same years of time, what's also been interesting is that home care has been rapidly growing and on the rise. And what you'll see here, this is data from NIHS, heart failure sort of leads the pack in terms of conditions in which people receive care at discharge. And this really started to pique my interest, especially with that, as you saw, the qualitative study where patients were relying on formal providers in the home. With funding from the American Heart Association, I actually wanted to sort of repeat that study with more contemporary data. And we used the Get With the Guidelines Heart Failure Registry, which I know folks here in DPM and cardiology use. This was a national registry of adults hospitalized for heart failure in the US with linked claims. And we found that actually 1 out of 3 adults hospitalized for heart failure are now going home with home care. And that utilization prevalence has increased in time, and I don't think it's slowing down anytime soon. You know, for those physicians in the room or the epidemiologists, I think many of us always think, well, okay, if people are getting it, who's getting it? What factors are associated with receiving home care? And in our study, and also confirmed by others, we found that tends to be if you're a woman or older, the more comorbidities you have, the more likely functional impairments, medications, polypharmacy, and then being in certain areas, so urban areas, the Northeast, and longer length of stays for that index hospitalization. So I doubt any of this is shocking, but I think it's also helpful to describe like the who of who's receiving it. And using claims recently, this study is under review. We actually looked at, you know, when you study home health, there's home health assessment files or OASIS part of Medicare claims. This was 100% sample. I just wanted to give you a sense of, you know, what are their needs at home? I think you can see here, at least for the heart failure folks, lots of medications, 97% are taking more than 5. Exhaustion, a history of falls. You can see a lot of shortness of breath, and just look at the prevalence of need. And then for some of you doing medication adherence work, I just want to show you like high proportion of people can't take them unless they get help getting them. So I think there's another riparian maybe to think about when formal care is involved. You know, I think in terms of health services research and healthcare delivery, I think the big question on my mind, maybe yours too at this point, is, well, okay, if you get home care, how does it influence outcomes? And I think there's a lot of potential. I think if you have extra trained eyes and ears in the home, there's really a nice way, if it could be leveraged, to reduce ED visits, readmissions, improve function, and also work on improving healthy days at home, which is a more novel or newer metric people are more interested in. It's all at a lower cost, right, than nursing home or SNF. And yet I would argue that the data is limited and mixed, and a lot of us have had our work cut out for us. I think some of that is there have been observational studies that look at, you know, what is the impact of home health on outcomes. My own have done this. I think the problem is, you know, there's always some residual confounding. You always have to account for, okay, the people getting home care, as you saw, are often more sick and have functional deficits. And so even the best propensity score matched or, you know, IPW weighted analysis, there's always going to be something that you couldn't account for. So it's hard to do some of these studies. Within individual components of home care, I'd say we've had a lot of success in nurse visits. This has been really, actually really positive. I'll show you in a second. But I would also argue they're hard to sustain in real life. Getting nurses in the home, a number of visits, you know, when a grant goes away, a lot of leading folks in the field say, okay, then the program kind of dissolves. And I think that's a problem. And I would also argue there's very few, if not only one, of RCTs, of like pragmatic RCTs of actually getting Medicare home health as it's prescribed. And I'll put a star there because that's where I'm going to come back to at the end of this talk. This is from a systematic review and a meta-analysis done in 2017 by Dr. Vance Fall, who I've had the pleasure of meeting at several meetings. And I love this because it looked at all the types of transitional care services patients get. And nurse visits, I'm going to show you, this is for heart failure, have actually done the best in terms of reducing mortality and also readmissions. But like I said, I think there are certain gaps. And I think one thing where hopefully this talk will leave you is that a key group of home care providers have really not been studied, and that's home care workers. And so, you know, nurses are a big care provider in home care and heart failure, But this study we just did using MEPS data. I don't know if folks have experience with that. It's my first time using it. We have home care event files, which I thought was pretty attractive. And we looked at heart failure from 2011 to 2019 and actually found that right after nurses, home care workers, this is actually, so not just in the post-acute period, but a community-based sample are being used, again, that 1 out of 3 numbers is holding steady. And so despite that, really not much research on this group, and I hope I can convince you, I think that's a missed opportunity. I think they're with patients for a long time. They're there observing and advising, and I'd say similar but different to other types of caregivers or professionals in the home. And so I'm going to give you sort of where the evidence stands on what I've been able to do. I just want to preface it by, I know some people I've met with today have had a similar trajectory. I tend to do observational work, and then in parallel or with it, and now intervention and some trial work. And so oftentimes, especially in home care where there hasn't been as much done, I've often started with qualitative work, I generate some hypotheses, tested quantitative studies with some cohorts or claims, that the findings from those, I'm having that lead into intervention work and then testing those out, doing some clinical trials, and it sounds like people here are pretty jazzed about implementation science, which is great. So you're going to see this figure come back throughout the talk, so get ready. Now you'll know what it means at the bottom of the slide. So how did I get started in home care? I think throughout the day so far, a number of people have asked me that, and I started by talking to home care workers. I wanted to know, what is it that goes on in the home, and how is that going, and what are some of the problems you encounter, and what's that like? And it was a pretty simple qualitative study. I'd say the rigor of it from my end was that to actually get a really nice diverse sample of home care workers, I partnered with the largest union in the country. This is 1199, they have branches all over, but in New York City, there's a benefit fund where they actually provide benefits and training to 75,000 workers employed by 55 different agencies. So that way the sample that I had really allowed me to get representation across the entire city. We did the study in English and Spanish, and we used thematic analysis because I started out with a conceptual model. And I'm actually just going to show you one table one for this entire talk because it typically is the same based on how I sample. This was from this qualitative study. We had 46 participants. They're about a mean age of 49. You can see it's mostly women. We usually have one man in every study, one or two, to Jeff to go with your man code. Mostly non-white. And as you can see, the education really runs the gamut, which I think is surprising for people. By design, we had language breakdown of 50-50. And these are folks that are actually in this job for a long time. So 16 years on the job. Went the wrong way again. In qualitative work, the findings are themes. And so the 3 major themes we found here, workers told us very frequently that heart failure was absolutely frightening and unpredictable. So they would explain, I was with this patient, everything was going fine, and then she became short of breath, and oh my God. And that was a very classic finding from this. Workers said, I actually am doing a lot. And they didn't say involved in heart failure care. They said, well, I take the weights, and then I take the blood pressure, and then I cook the meal that I'm supposed to, and I remind them to take meds. But they, when we probed them, I said, well, where'd you learn that? I've never received training. I don't know, and I don't feel confident about doing it. And that really stood out to us too. And lastly, I think a big issue we found was that when they needed help, they could not get in touch with supervisors in the field. So a patient would become symptomatic, could not reach their agency nurse or the patient's doctor, no idea who to call. And it resulted in 911 calls, which we thought was a big problem. And so I didn't just want to get the perspective of workers. I actually wanted to, if you think about home health, there's a lot of stakeholders involved. And I think we talked about stakeholder engagement earlier. And I think to me, there's a lot of different people that need to be in the conversation. So we followed that study up with a qualitative study with 80 different folks all the way from family caregivers to doctors, care coordinators in the hospital, home care agency CEOs, you name it. And this was the first study of my career, and since then, where there weren't themes, actually a graphic was the final product. We published this in JGIM, and I guess they bought it. But really what came out, everyone started to draw a picture for us. And we thought, isn't that interesting? Everyone wanted to walk us through what happened. And I thought, well, okay, walk me through it. And so actually in my office was lined up all these things that people were drawing. Basically, patients would go home from the hospital, maybe there's a family caregiver involved helping, maybe a home care worker came in. And as you can see, for the clinical folks, this really reminds me of like the neural pathways in medical school, right? So they'd often say, someone becomes symptomatic, and then there were different pathways that would happen. The aide could either manage the symptoms, call the nurse for help, or call 911. And unfortunately, when there was a lesion or when there was a problem in one of those pathways, there was a lot of 911 calls. And I think as someone who wants to do work to improve healthcare delivery, that to me was a major problem that again sort of came out here as well. This is where the qualitative for me really we needed to start looking at this with larger data sets. And as part of my K-23 from NHLBI, I wanted to survey home care workers across New York City to understand, are these qualitative themes real? Can we quantify them, and can we test some associations? For example, how do we know, this issue of confidence, is that maybe a mediator in all this in terms of their contributions to care? What is it about training and job satisfaction? And so we've surveyed now 800 aides across the city just to try and get at some of these questions. And in the process did some scale validation. As you can imagine, a lot of the validated scales to understand contributions to care have never been done in paid workers. And I was actually trying to get in front of journal reviewers who are going to slap me on the wrist for that. And also so we could use these as endpoints in a future trial. And so I'll just, before I go into it, this is the conceptual framework we use for this survey. It's built on situation-specific of theory of self-care and caregiver contribution. What I like about it is that I know Dr. Connor's work, there's the dyadic interface, but also just when caregivers are involved, there's often this process in heart failure of monitoring and maintenance, and ultimately outcomes at both the worker level and the patient level. And you'll see in the trial that I'll show you in a few slides, really trying to measure both of those things. Again, I won't go through the demographics, they're pretty much the same. What I will say is that finding that aides didn't have heart failure training definitely bore out here. You can see 63% had none or a little heart failure training, and about 42%, only 42% said they had adequate self-efficacy or confidence. This was helpful for us just to get a sense of, okay, this wasn't just we were able to see this in a larger scale population. Going the wrong way. We did find through mediation analysis that self-efficacy seemed to be a major driver in relationships to how aides were able to contribute to self-care. As part of my K, I actually got training in how to do these modeling. It's just really nice growth for me. And so actually it seems to be that all roads kind of go through how confident that aide feels. Preparation didn't seem to matter much unless they felt able to carry that out alone in the home. And just to get to the 911 calls, because I think as a primary care doc or for hospitalists or anyone, just this broken system of not being able to reach people, we actually, these are not validated questions at all, but we really just said, have you called 911, and could that have been prevented if you could have reached someone? And nearly 50% said agree or strongly agree. And then we asked about the doctor, and the same percent. So these really just stood out as gaps to us, and things that perhaps we could fix. Which brings me to community engaged intervention design. And hopefully some folks in the room I know have experience with this. So we'll definitely do questions at the end, but I will say we focused initially on training and communication challenges as two areas of intervention for this workforce. And I think for me, what I find so fun about this area is that not only could you improve things for the worker themselves who's in the home, but the potential to then have that improve patient outcomes. I would be remiss if I didn't highlight my community advisory board, which I formed back in 2018 or 19. It's a key group of home healthcare workers. We meet every 8 weeks. I would be, it's impossible as a physician to actually know what's going on. And so I really rely on them for a lot of the aspects of research. We have an ambassador program, and it's just been wonderful to get their input along the way. And also, for example, how do you interpret things and then bring them back and disseminate them, which has been great. And speaking of, I think that was critical. We brought to them this idea of, it seems like home health aides want training. What do they want training on in heart failure? And I want you to, when you're listening to this could also easily, I'll show you in a second, be translated to dementia or whatever other disease. But this was we did nominal groups and focus groups. We asked them, when caring for a client, what information is most important? And you can see signs and symptoms are up there, treatments, communication issues. But I think what's really telling is we asked them, what situations do you struggle with? And we thought it was going to be, chest pain or shortness of breath. Interestingly, like addressing the diet, getting people to take their meds, getting people physically active in the home. And so I think this was really, I'm glad we took an extra year to do all this because it allowed us to, I think, design something that was unique for this workforce and their scope of care. We used a theory-driven approach, adult learning theory, where, case-based learning, just like for medical students in a way. Motivational interviewing was actually 1199 was very adamant that every single case have motivational interviewing, because if you think about it, if you're in the home with an older adult, or you really need to have skills to be able to get them to kind of do what the plan of care says, and that's takes some skill. We did this all, and I can't see it because the little Zoom thing, but that should be a Zoom screen behind it. The goal was to do this all in person, and then COVID happened. So we switched actually to do everything virtually, which actually now in retrospect is fantastic because it's scalable. And you can see it's a 2-hour course. We actually have it taught by a nurse practitioner and a primary care doctor initially from my practice, which again, for me has been a wonderful way to involve the medical educators. This is what they shine at. You'll see that they lead the papers, which is fantastic. Now at this point, we're in a train the trainer model where folks at different home care agencies are actually leading the course, which to me, again, sustainability. Just some examples of some of the work, slides. Interestingly, aides really wanted help with triaging. So when is a symptom something they can just kind of hang out with versus escalate and then 911? And so we actually designed decision support informatics for them, graphics for them, and actually converted this all. Another issue we found from our advisory board is they didn't just want to take a class. They wanted to have a way to access the materials on the job. So we partnered with our tech campus to actually make an app that has everything in the class. You guys can go on the website, it's free, and they can access it, including this traffic light triage system where you enter in the symptoms and it tells you sort of what level of care, what you should do based on home care agency guidelines. We piloted this last year. This paper should be coming out in a month or so. This was actually a very simple design, a single arm mixed method study, because I think our goal was really feasibility. Is it possible to train a workforce to have them take this virtually? Are they going to find it engaging, and will they learn something? And so we tried to do that. Again, we partnered with a large union to do it in both languages. And I just want to point out, we actually wanted really, you'll see some of the baseline scores. We were after aides who could eventually lead the course. So we started actually with a pretty high knowledgeable, pretty confident group, because we wanted to make sure that, okay, if they took it and liked it, could they eventually be the ones to at their agencies lead it? We used the RE-AIM framework and the health equity implementation framework to sort of frame the outcomes. And, we got 48 aides to complete the course and do the post-course survey. All were women, and most were really satisfied. We had high levels of engagement, but I think that what people said was actually more telling. People liked the real life cases, and I love the one at the end, sort of, I applied what I learned to my patient the next week. And I think that for me was just on a personal level, just really gratifying. This was, we looked at pre-course scores, again, simple study pre-post, but we did see statistically significant improvements in heart failure knowledge, contributions to care, and confidence. And because this was a group that started off being at a high level, we actually stratified by low and high scores. And you could see that the major gains were actually in the people who started off at the lower level, sort of like most medical education interventions. Limitations I've talked about. We also actually in this, we did not have any data on the patients they're caring for. Again, by design, you'll see in the next trial we do. But it was feasible, people liked it. And I think there's potential for scale, which again, it was something that our community partners were really wanting us to work towards. I actually had a lot of fun. Aides apparently liked it, and we got approached by the local television station to talk about it. And we prepped several aides for TV, and at the end, all the workers at her agency signed her uniform. And it was a nice thing when 2 or 3 years later, you see sort of the product play. Just a fun slide. In case you're wondering, are other people doing this? The answer is yes. We're seeing more and more of this, for at least I put a couple examples from dementia. Folks out in UCLA are working on this, and others trying to really translate training this workforce for other diseases. Some of you who do multiple chronic conditions, I think that's a natural extension, one where I hope to head as well. People don't just have one condition, they have a lot. But I think this is catching storm. Communication challenges were the next piece that we really wanted to tackle. And I think the first step with that, I don't know about any of you, but for me, I felt like I needed to understand the lay of the land in terms of home care. There's so much out there right now with remote-based monitoring, right, and all this tech, but what is out there for home health providers? And this was one of my early grants when I was on faculty from Robert Johnson. And we did a lot of qualitative work. We did a scoping review, which should be out in JMIR next week. We found that it's really highly variable. So there's a lot of non-digital aspects of care. What I mean by that is you might have an aide in the home who's taking a blood pressure and she'll write it on a scrap of paper. We've heard that over and over, and then it stays in the home and is not transmitted anywhere. And maybe it comes to me in primary care 2 weeks later, in which it's not very actionable, right? There's also this thing called anyone heard about like a care plan, which every home care agency makes. Some agencies, they're standardized and on a tablet. Other agencies, it's on the refrigerator with a coffee stain. Nothing's right. Like it's just.
I think Nami, are you laughing at what we get in primary care?
Yeah,
It's like this.
You have to sign it.
Yeah, 6 pages of like
Don't even want to read it.
7 points. All to be good.
Sure. Yeah, I'm just signing Madeline Sterling, MD, done. Right.
Yeah.
And it's not integrated. I think then there's also, we found this incident call chain system where you have an aide who's trying to call the nurse, can't get through, tries to call a coordinator. You could imagine this takes days, all the while a patient's not doing well. And then lastly, I mean, you've probably seen the health tech space is really in trying to get into home care and family caregiving. And yet all the apps and all the sort of tools for this workforce are most of them, we just paper out next week on this. Most are just to track aides. So like a GPS system, did they get there? Many are to actually book shifts. So like, hey, we have a new patient 9 blocks away, you want it? And none of them, there's very few that are meant to actually support the workforce for the work. And we thought that was a big problem. We actually brought these issues back to one of our leadership boards, and I gave them the top 5 and said, help me prioritize, what do you think we should tackle? This was a couple of years ago. And they said, help workers, get knowledge, give them gaps for that decision making. So we tried to do that with the training. And then they said, connect them to the supervisors. Again, not the most complicated intervention, but that's what seemed to be that issue, like connect people when they need help. And so this is just a slide. We got a COPI of an NSF grant where they have a portfolio around human design and work. And we sort of said, there's a lot of work to be done in home care. And this is just a model of how we've been designing technology. I partner with computer scientists. We do a lot of qualitative work and then prototypes and paper mock-ups, all then to do some final testing. And just to give you a sense, because I think that's a little hard to comprehend, this is what we put together, for example, in heart failure. So you have this green, yellow, red, which should now look familiar, that triage system for symptoms. We built this as either a tablet or an app for aides, and then at the bottom is a chat. So an aide could actually chat a problem to her nurse at the agency. I think that's all fine, but again, in the spirit of dissemination, I really wanted to, rather than design something new and spend years on that, I wanted to work with companies that were already contracting with agencies and with unions. And so Care Connect, at least in the New York City market, I'm sure there are many here in Chicago, it partners with a lot of the larger agencies. It's actually an app designed for this workforce, and they provide training through this app. Interestingly, they agreed to have us give us a chat feature, which was really fun. As I sort of said, look, I'm glad you have these apps, but we'd love to use it. And so this is what kind of we pitched and what we're now doing. So an aide who's logged into this Care Connect when she's on her shift can say, hi nurse, my patient's legs are more swollen, and the nurse can say, well, how far? And you can see this is sort of a very easy chat-based system to check edema. I don't think this is complicated. It's sort of just a first step to connecting people, and that's kind of, to me, one of the issues that I thought was really a problem in home care. So Where am I going with this is that as part of my K-23, I'm partnering with VNS Health, which is one of the largest agencies in New York City. We're actually testing these interventions on both home health care workers, but also the patients for whom they're caring. This is my first clinical trial, I hope the first of many. And just to give you a sense, the goal is, can you train home care workers about heart failure, provide them with this app that allows them to connect with their supervisors. And the hypothesis is that training and just training and integrating them, does that improve their ability to care for patients, but also the patient outcomes. And so, I could probably spend a whole talk talking about this trial and all the hurdles and ups and downs with it. But aim one is really feasibility and acceptability. It's a pilot feasibility study. Two is looking at outcomes. It's actually powered at the aid level, so looking at knowledge and self-efficacy. And then the exploratory aim is at the patient level. And by partnering with an agency that has claims data, we can actually get hospitalizations, readmissions, days of care. And just to bring that, the goal is to avoid that revolving door. This is a schematic of what this trial looks like. We kicked off this spring. So far, so good. Doing it all virtually, which is interesting. But I think it's working. I don't have data to show you yet, but basically each aid is in it for 90 days, and then at the end of the 90-day period, with a mixed method design. So really survey work before and after, at 4 points in time, and then at the end also interviewing with patients and also getting outcomes on the patients. And hopefully this will then give me the data necessary for the R01 to follow at a larger scale and powered at the patient level. Using the PRISM REAM framework for this, and I like this framework because it's one that allows for the policy and organizational context of an intervention being tested, and so it seemed like a nice fit for a intervention that's being delivered in a home care agency. I think it's also nice for, again, studies that bridge the home care to hospital, which is hopefully where the work will turn in a couple of years, and so stay tuned. Again, I'm going to do this for every single one, just so you think I'm not the only one in this space. I will say there's actually a researcher at U of C here in Chicago who's doing a similar thing. She has the Pro-Home RCT. She's looking at dyads of home care workers and patients, seeing if workers can be leveraged to help patients with physical activity in the home. And then there was a R21 looking at can aids be leveraged to coach patients after stroke to reduce falls and improve mobility. So I think this area is ripe for study, although there's not many of us, and come join, it's a lot of fun. Anyone know where this is? This is Chicago, and I did want to do my homework and just to say there are a lot of agencies here. I've certainly spent a lot of time getting to know the ones in New York. Once you know one, you sort of dovetail and get to know a lot of them, and I think there'd be a lot of potential. So I think I'm good on time. I'm going to, for the next 10 minutes, just talk to you about some other areas of research in my portfolio, and then give you some clinical and policy implications for hopefully your line of work, and we'll save some time for questions. I would say there's 4 main areas that I also study. One is hoping to move into sort of implementation science and doing some hybrid trials in home healthcare. I think that's a major gap right now. I'm also working on some technology for not just home care workers, but also paid caregivers and then family caregivers for older adults. As I alluded to before, this workforce is there's a lot of inequity health-wise and occupationally, and I think I do have an epi background, but I also want to change things, not just identify the problem. So I'm working on interventions to actually improve the health of the workforce themselves and also hopefully increase wages. And then finally, there's a lot of changes in home care policy, and I think it's hard to do the work without knowing that landscape. So I have some work in that space as well. So I'll go through each one, a couple of slides for each. So I started off with this first slide in the beginning, asking, telling you that what is the impact of home care on outcomes in heart failure, and that we know nurse studies work, hard to sustain, and we know that there aren't that many trials, pragmatic trials. And I would say this is, I just submitted this R01 to NHLBI, and it's called iTransfer, and it's really about improving transitions of care for heart failure patients in home health, not with a focus on the end, but actually a focus on the bundle of services patients get. So there was an R01 from a collaborator of mine, 5 to 7 years ago, that actually found that for patients discharged home from the hospital who get home care, actually, if they got two things, if they got early and intense front-loaded nurse visits, so they were getting home care, but they got those nurse visits like 3 in the first week, and they had an early outpatient doc. So within seven days of discharge, they saw primary care, cardiology, geriatrics, saw somebody. They got those two things together. They actually had really, 8% absolute reduction in readmissions, 40% relative reduction. And then nationwide, though, that study using national claims showed that only 12% of Medicare beneficiaries actually got that. And so in the trial I'm proposing, I'd really like to actually test this in real time. So how do we give people early and often home care and outpatient follow-up? It's a type 1 hybrid. So the first aim is the effectiveness aim, doing a stepped wedge RCT. And actually it's dyads are getting randomized to the intervention. So these are hospitals and they're referring home care agency. So for example, if Northwestern were a site, it would be the hospital here, and then a referring home care agency could be one of the sites. And every dyad is sort of being asked to turn on this workflow. So the inpatient site team would be making it early follow-up visits for everyone, and the home care side would be getting home care in the home early and often. And I think what makes this feasible is that all the outcomes are being ascertained, but like via claims centrally, and seeing what happens. And the aim too is the implementation aim. So interviewing stakeholders at all the sites to understand, what worked, what didn't, is this feasible? And this will use CFR as a framework. So wish me luck. Technology wise, I think, and I tried to highlight what's going on here. I think I've been very interested in what technology is there to support older adults and their caregivers. Lee, I know you're on the line. I wanted to shout out what you guys are doing with some voice controlled assistance. There's also some other work going on at U of C. So I think this is of interest, at least here locally, looking again at conversational agents. So sort of people in the home getting sort of input from Alexa is an easy way to say it. I love this space. I think for good or bad, I think, patients we're noticing in our work have either positive reactions to it or negative. And I think there's a real role for caregivers. And so our lab is part of it is looking at extended reality to support caregiving. And so just to orient you on the left, picture a home, and the caregiver is the green figure wearing like a headset, and the patient is in blue. And basically you have a remote clinician also wearing a headset describing to the caregiver what to do. And NSF is funding this. You can laugh, but I think we're making progress. This is a prototype. This is what it looks like in the lab. Have a local caregiver getting advice from a remote clinician. And at least through focus groups, we found that people want guidance. They want to know what to do. As you've seen with the paid caregivers, I think there's a lot of, we want to help, we just don't know how. And so what is this? Oh, good, it worked. I didn't know if it would come up. What does this look like in real life? I just wanted to put in some point of view feeds. The local view at the top A is what the caregiver would see, sort of like helping them. This is checking for edema and heart failure. On the right-hand side, you could see at the D, this is like the clinician who could be anywhere kind of giving the input. So a little different from voice assistants, but in a similar line of providing some more support in the home. And hopefully the goal is to, now that we've done designing it, pilot testing it, we'll hopefully be able to test it in a large scale in the coming years. Hopefully at maybe NIA would be interesting. Health and occupational inequities. I think, this is a vulnerable workforce that I tried to show you. I could do a whole talk on that, especially we've done a whole lot of work during COVID, but home care workers have poor health. I think it's not surprising why, right? They have really low wages, underinsured, work is really hard, it's manual, they get injured, there's no time to go to the doctor, they don't have insurance, so little time for self-care. And we've actually found nationally that their health is actually worse than other age, sex, and race matched other frontline home care workers not in the home. So there's something about the home environment, it's isolating, there's not standardized equipment. And then of course, this was exacerbated during COVID. I actually did this work. Does anyone use BRIFMIS? Behavioral risk factor survey. Use it? Yeah.
Never called it that, but yeah.
Yeah, BRFSS. Either way. I like, this was a nice one because I was very interested in understanding the health of workers, but it's very hard to actually find a database where the industry and occupational codes are linked. And so I wanted a database where I could get both health and job. We found that pre-COVID, like 1 out of 5 workers have poor mental health. And post-COVID, we actually surveyed workers in 6 languages in the Northeast region, finding that 70% are now struggling with mental health. Cardiovascular health, I mean, if you look at these risk factors, the prevalence is really high, and again, higher than other similarly low-wage workers. And if you think about it, I mean, I think about my patients. If my patients are in the home with diabetes, arthritis, heart failure, all sorts of stuff, dementia, and then you have a caregiver who's not healthy, doesn't have good habits, sort of seems like a recipe for disaster. And so I've been really lately interested in designing behavioral health interventions to improve the health of the workforce, with the goal of, if we could improve their health habits and health, could we then eventually study the impact of that on both the aide and the patient? And luckily, this work is being funded. Leading the first trial of improving the mental health of home health aides. Doris Duke is funding this, starting that up in the next year. We're adapting existing health program aides to love peer coaching. I think it helps with isolation. We did a pilot during COVID of this virtually, and I think what's nice is, again, that potential for scale. And also it allows for career advancement. So we've now worked with plans to say, if an aide goes through this program, becomes a coach, might they have additional certifications and kind of go up the chain. And we got a pilot from NIMHD to actually do cardiovascular health. Lastly, just to say, value-based purchasing is coming to home care. CMS is changing how it's financed, moving away from, like many other areas, fee-for-service to VBP. And I've really been fascinated about what this means for agencies, but also patients. In VBP and home care, basically home care agencies are now being graded on what's called a total performance score. So how they did on those OASIS home health measures, which you saw a little bit at the beginning, that function, and then satisfaction surveys, but then also acute care hospitalization. So if your patient's going to the hospital or using the ED, you're going to get dinged as an agency and be financially penalized for that. CMS actually piloted this in 9 random states, let's say several years ago, and now based on the findings of that, it's actually expanding it to the rest of the US. Chicago and Illinois were not in that pilot. I put in, recently got this grant from the Research Institute for Home Care to actually study what's happening on the ground. So doing a national qualitative study with stakeholders from both the states that already implemented it in blue, dark blue, and then light blue in ink 2. And then lastly, we're going to convene an expert panel. And my hope is that with this data, probably the R1 to follow will be a quantitative grant looking at the impact of the policy on patient utilization and outcomes for older adults. Sort of what is the impact of the expansion of the policy? So what are some implications? I think the first thing, this is a medical grand rounds. I think first is just awareness of home care workers. I think they're in homes. They may not be by themselves, they may be with family caregivers, but knowing that they actually do far more than I think the medical field has thought them to do, and just be aware of that. And I think there are gaps in training and integration, as I showed you, but I think there are ways to incorporate them when possible. So in my own clinical practice, obviously a patient has to agree, but I'll often say, you came here with your aide, do you want her to join our visit? Is there something that she might contribute? And then obviously research-wise, I think, hope to show you there's a lot of areas to go with this. I think we could definitely translate some of this heart failure work to other conditions, dementia, people with multiple chronic conditions, frailty. And I think there's observational work to do, but also really important translational and implementation work to do. It really just has not been a setting in which we've rigorously studied sort of what happened and how do we leverage it, and then connecting it to the health system. And finally, one thing I love about this space is just avenues for advocacy. I think I've been lucky to be a part of some recent legislative efforts to try and get workers higher wages. I think what's nice is, I think if you do research, it should inform clinical care or change policy. And what's nice about this, I think, topic is it could do maybe both. So we hope to kind of keep working and get better conditions, better training, all those things. So if I can figure out the clicker at the end, that's it. I'm at the 50-minute mark, and I'm happy to take any questions you have.